Hey guys, and welcome back to another episode of Next to Madison. On today's episode, we are talking about a very important subject matter that not a lot of people know a lot about. So with me today, I am actually sitting down with the founding executive director and chief science officer of the Alzheimer's Drug Discovery Foundation. And I am sitting with Dr. Howard Fillit. Welcome to the show. How are you?
Thanks, Madison. I'm doing good. How are you?
I am good. So I'm excited to talk about this, even though it's a very hard thing, and most of us have some experience with it where we know somebody who is affected by this disease. So if you could kind of explain, maybe to start, like how you got into this
Sure.
research of Alzheimer's and.
Sure. About 40 years ago, I was an internist. I am an internist, taking care of older people. And one day, I had the opportunity in 1980 to walk into a building, which was at the time a teaching nursing home. Not too many doctors go into nursing homes, and I had never been in one. And when I got in there, it was actually a beautiful building with 300 people, 300 beds.
Okay.
And we went on a tour, and the director told me that these 300 people that I was seeing, that most of them were bedridden, kind of zombies, kind of really like humanoid. You know, they couldn't talk and didn't know where they were. And they told me that these people had Alzheimer's disease. Now, at that point, I had been in medicine for 10 years, and I had never heard the word Alzheimer's disease.
And this was 1980, right?
This was 1980.
Okay.
And so it just amazed me because, for one thing, I learned that this was a disease of the human mind.
Yeah.
And that's really unique. You know, a lot of diseases affect the heart, the lungs, or even in the brain. Sometimes your motor symptoms, you get paralyzed. But this was a disease of memory.
Yeah.
Which was fascinating to me because I was a neuroscientist at the time as well. And so for me, it was an area of wanting to improve health care because these people don't get good health care, and wanting to figure out why people were losing their minds to this horrible disease,
Right.
which was actually, although it was discovered in 1906 by Dr. Alzheimer
Okay.
in a 52-year-old woman who was demented. And at the time, dementia wasn't really recognized as a disease. Senility, for example, was thought to be a normal part of aging.
Okay.
And everybody, back history, the Greeks, the Romans, whatever, thought that senility was a normal part of aging. You got old and you lost your mind.
Right.
But what Alzheimer saw in a 52-year-old woman was that she was losing her mind. She was becoming senile at 52, and he realized that she had a disease. So when she died, he did the autopsy, and he stained her brain with some dyes that were actually being used to dye dresses pink. They were chemical dyes that pathologists were using at the time to stain tissue. And he discovered the plaques and tangles that characterized the disease in the brain at autopsy. So he put together what's called a pre-senile dementia, a 52-year-old woman, with the pathology of plaques and tangles, and that became Alzheimer's disease. And between 1906 and 1970, nothing was done on research. And 1970 was the year I started med school. And what happened in 1970 was that some doctors working in London, they had an interesting question. They said, gee, all these old people are dying and they're senile, and maybe they have Alzheimer's disease. So they did an experiment where they used the same dye that Alzheimer's used in 1906, and when these older people died, they stained the brain, and sure enough, the old people had plaques and tangles. So it was that day in human history in 1970 that senility, which Shakespeare wrote about and everything, normal part of aging, became no longer a normal, thought of as a normal part of aging, but recognized as a disease of old age. And so that's why when I went to medical school, I never heard of Alzheimer's because we didn't know anything about it.
So why do you think between 1906 and 1970 there was absolutely zero research done? Obviously, people were being affected by it, but do you think it was lack of funding?
No, it wasn't lack of funding. That's a really great question. I never actually really thought about it too much, but I think there was so much bias that senility was just how you got old. You lose your hearing, you lose your vision, and you lose your mind.
Okay.
And these doctors working in London just had this really important insight that maybe they could do an experiment and see what was going on, and they found the same plaques and tangles that became the first clues for drugs and defined what we called at that time senile dementia. It went from being so dementia is a word. A lot of people ask me this, like, what's the difference between Alzheimer's and dementia, right? So if you think of senility, that we use that word to describe older people who are losing their minds. They're forgetting things. They're not talking right. They're getting confused. They don't know where they are. Those are all cognitive deficits.
Okay.
We in the lay term is senility. The equivalent of that would be dementia. So senility describes somebody. Dementia in medicine describes the patient, but it's not really a diagnosis. It doesn't tell you what the cause of the dementia is. It doesn't tell you what the cause of the person's loss of mind is. So Alzheimer's is the most common cause of dementia. 70% of people who become demented in old age have Alzheimer's disease.
Okay, so it's not one or the other. They're both in the same kind of class.
Alzheimer's causes dementia. It's like saying...
So you have to have Alzheimer's first to get dementia.
Correct. Alzheimer's is a disease that causes dementia. It's like if you came into my office and you were pale and you were weak and I took your blood count and it was low, I would say you had anemia.
Right.
But that doesn't tell us why you have anemia. It doesn't tell us the cause. And then we'd evaluate you, why do you have anemia? Do you have a cancer, God forbid, or something like that?
Right.
So it's like that. Anemia would be like saying somebody has dementia. It's a syndrome, describes the patient, and then we look for the cause.
Okay.
And Alzheimer's is the most common cause of dementia. The second most common cause of dementia, especially in older people, is vascular disease of the brain.
Interesting. So, like, my grandmother, she's almost 93. She's in a memory care facility of a assisted living, and they always say she has dementia.
Yeah.
But she knows who we are. Like, she just will say things like, "Oh, I was in New Jersey yesterday."
Right.
Like, really? How'd you get back from New Jersey?
Right.
Right. You're in Colorado right now. So she does stuff like that, but it's interesting how it works. Like, 'cause she knows who we are, so we wouldn't say, "Oh, she has Alzheimer's," typically.
Well, yeah. What's fascinating is about how the mind degenerates and what things people lose along the way. So the first thing that happens is short-term memory goes. So, like, one of the most common complaints early in the disease when it first presents to family members, like, a spouse or a child or something, a daughter or a son,
Right.
is, let's say you're living with somebody, you've been with them 50 years or whatever, now they're 70, and, you're saying, okay, tomorrow we're going to go to the movies, or tonight we're going to the movies. Okay, great. And you go to the movies. But then if somebody starts having short-term memory problems, you might say to your husband, we're going to the movies tonight. And then 5 or 10 minutes later, they might say, well, what are we doing tonight? And you say, oh, we're going to the movies tonight. And then 5 or 10 minutes later, you'd say, well, what are we doing tonight? And, it's that kind of really bad short-term memory. So that person would have all their memories of childhood and what happened 10 years ago. But anything that you tell them that's short-term memory, where they need to register something in their mind and remember it, that's gone. So, scheduling starts to go, the ability to pay bills starts to go, sort of complex cognitive tasks become difficult. People can't work because they can't remember things.
Right.
Abstract reasoning starts to go.
Okay.
The ability to multitask, what we call executive function of the brain. It's a neuropsychological term to describe the way people lose their minds in terms of being able to have insight.
Okay.
And one of the things, you might say, they don't realize that they're losing the memory because they're losing insight. But some things don't go until late in the disease. For example, if you have a little baby, right, it's 6 months old, imagine that baby recognizes a mother's face. It's one of the earliest things that human beings have is facial recognition.
Okay.
And it's very deep in the brain. And so it's one of the last things to go. And that's why the story you just told of your
grandmother.
Your grandmother, she doesn't have good memory. She's not oriented. She doesn't really know where she is, but she remembers your face because that's so deep in her brain. And music is another thing that's really deep in the brain. Imagine when you have a 1-year-old or a 2-year-old, the mother might be singing lullabies to the child, and the child recognizes the music because music is so deep in our brain. It's such a fundamental aspect. So, like, my dad had Alzheimer's disease, and he used to get really agitated because he was in the nursing home, and he thought he was in a hotel, and it was just a horrible situation. And they used to give him a lot of drugs. And then one day, this person that I met, actually at a TV interview, told me that he had started a foundation where he was, this was several years ago, making on iPods, he was putting playlists and giving them out to nursing homes to try to help treat people who were getting agitated. So he asked me what my dad's favorite songs were, and I told him some songs that I knew my dad liked back in the 1950s. So he said, okay, I'll make him a playlist on an iPod. And, my dad was on a lot of medication, but then the next time he got agitated, they put the iPods on his ears, and they played the music for him, and he just calmed down. He started crying. And so he could recognize the music even though he thought he was in a hotel. So, what we lose as we progress in the disease is the ability to function. Okay, so in the early stages, the ability to function, you can't work, you can't pay bills, you can't do scheduling, this kind of thing. You start losing the ability to use the telephone, to use the computer, and that kind of thing.
Okay.
And then as the disease progresses, the more basic, what we call activities of daily living, start to go. Things like being able to dress yourself, to be able to pick out your clothes properly, to be able to groom yourself, to be able to bathe yourself, to be able to go to the bathroom by yourself, even to be able to walk. And eventually, people forget how to walk. They forget how to go to the bathroom. And eventually what happens is people forget how to swallow. And when people forget how to swallow, the food repeatedly gets in the lungs. And that's the most common cause of death from Alzheimer's disease, which
that's what causes it?
Aspiration pneumonia. They aspirate food into the lungs, and you can't really treat it. Even a feeding tube doesn't help. So people don't realize that Alzheimer's, it starts out as a disease of the memory, but it's actually a chronic, progressive, and uniformly fatal neurodegenerative illness.
So if somebody starts noticing these early signs in their loved ones, what is the first thing they can do? Like, what's the first step to take?
The first step is to go to some doctor who knows about how to diagnose dementia, let's say. Let's put it that way. Because the reason I say that is as we age, memory does decline a little bit, processing speed. So your brain has a processing speed, just like your computer has a processing speed, and your processing speed peaks at about age 20.
Okay.
And then after that, it just gradually goes down and down and down. And by the time you're 70, it's about half of what it was at 20. So if you're 30, it's not what it was at 20.
Oh, so we're getting slower?
Slower and slower. Although exercise actually helps to maintain the brain's processing speeds. That's kind of interesting. It's another subject.
Okay.
But the point is that as we age, there are changes, just like in every other organ. There are changes in the brain functioning and cognitive function. So the role of the doctor in those early stages is to try to distinguish between what's normal aging and what might be the earliest signs of dementia. Okay, and I say dementia because we're trying to decide whether somebody is really affected and they have dementia, and then we'll figure out the cause after we decide if they have dementia. Does that make sense?
Right. And what is the thing about how some people are getting Alzheimer's earlier and earlier?
So rarely there are mutations in a protein called beta amyloid. And what was found around 1984, that I mentioned those plaques that Alzheimer described. So it was found in 1984 that one of the major components of the plaques in the brain, which are kind of like these abnormal deposits, is this protein called beta amyloid. And the gene for that protein was found in 1986. And so then there were families that were being discovered, very rarely, where everyone in the family got demented in their 30s and 40s. So the average age of Alzheimer's disease is about 75.
Right.
But so it's a senile dementia, right? But if you remember, I told you about the 52-year-old woman.
Right.
It turned out she had this genetic form of Alzheimer's, which was a mutation in that beta amyloid protein that's in the plaques.
Oh my gosh.
And so there are families around the world that have mutations in this beta amyloid protein that causes Alzheimer's disease. It causes them to get demented in their 30s and 40s from Alzheimer's disease.
Oh my gosh.
But it's really rare. It's like less than 2% of all the cases.
Right.
But what it teaches us is that that this mutation in the beta amyloid can cause Alzheimer's. And what happened from that was that became the primary drug target for drug development for Alzheimer's.
For this beta?
For the beta amyloid
Wow.
protein. So tens of billions of dollars has been spent over the last 20 years last 20 years or so by the pharmaceutical industry on trying to fix the beta amyloid, either remove it from the brain where it's being deposited or prevent it from being produced. And unfortunately, so far that strategy hasn't worked, except very recently, a company called Biogen spent about $3 billion taking a risk on seeing if their vaccine, and it's called a vaccine, could remove the beta amyloid from the brain of people with Alzheimer's disease, right?
So everybody has if they have Alzheimer's, they have this beta.
By definition.
Okay.
They have beta amyloid in their brain,
Okay.
by definition.
Gotcha.
And it's thought to some degree that the beta amyloid kills brain cells. That's the cause to some degree or another. By the way, the brain cells die and you lose your mind. That's how it happened.
Oh my gosh.
So one of the theories was you could make this vaccine and remove the beta amyloid. So there were a lot of clinical trials, tens of billions of dollars spent, and they all failed.
Mm-hmm.
But what happened was that we didn't know for sure which people that were going into the trial actually had beta amyloid in their brain because we couldn't see it.
Right.
And so,
oh gosh.
So what happened was, I'll tell you a little bit about our foundation. A guy calls me up from the University of Pennsylvania in 2000. And he says, Dr. Fillit, I have a crazy idea. I said, what's that? He said, I want to take the same dye that Dr. Alzheimer used in 1906 to define the disease, right?
Right.
And I want to radio label it, right? I want to put a radioactive fluorine on it, which is commonly done.
Okay.
I want to inject it into the artery of a person, a microdose, so there's no radioactivity risk. It'll go up into the brain, and it'll bind to the plaques if they're there, and you could see the binding on the plaques on a PET scan, which is a routine radiology exam, right? You can go to almost any radiology office in the country today and get a PET scan.
Wow.
So we funded him for 4 years at the University of Pennsylvania, and he made the radioactive dye, and he showed that you could inject it into the vein of a person with Alzheimer's, and sure enough, it would light up the plaques. So,
wow.
Before that, the only way you could see if a person had plaques in their brain was either by a brain biopsy or by an autopsy.
Right.
And not many patients want to go through an autopsy to find out if they have Alzheimer's disease.
Well, yeah, then they're already gone.
Okay, thank you. So, is that me?
Who's calling you? You're forgiven.
So,
So he figures out this dye, so it lights up the areas now. So now you can actually diagnose people.
right.
With
So what happened was we funded this thing for 4 years at Penn, and then in 2005, Penn spun out a biotech company called Avid Radiopharmaceuticals to develop and commercialize the test.
Okay.
And in 2010, the company was bought by Eli Lilly, the big pharmaceutical company, for $800 million.
Wow. Okay.
And what happened, the reason Eli Lilly bought the test was because they were running a clinical trial of a vaccine to remove the amyloid from the brain of the patients.
Mm-hmm.
But they didn't have the test, so they wanted to actually find out of all these 3,000 people that were being enrolled in clinical trials, how many of them actually had the target of the vaccine in their brain and how many actually had Alzheimer's disease, right? Because if you don't have plaques in your brain, you didn't really have Alzheimer's disease.
Okay.
And it turned out that 35% of the people who were in this clinical trials for a vaccine to remove the beta amyloid had a negative PET scan, and they didn't actually have Alzheimer's disease. So it proved that doctors weren't always right in making the clinical diagnosis, and you needed a diagnostic test.
So what was wrong with the people that didn't have that?
Well, they had another form of dementia, like maybe the vascular dementia.
Oh, okay.
Okay.
Interesting.
So that might have been why all these drugs failed. Because I told you we spent tens of billions of dollars and we had so many failures. It would be like trying to develop a drug for heart disease if you didn't have a blood test for cholesterol.
Right.
How would you do
nearly
that?
Impossible. Yeah.
So So then Biogen, this company I told you about a few minutes ago, they come along, and for the first time, in order to get in the trial, you have to take the test that our foundation helped to develop, and you had to have a positive test to get into the trial. You had to have the beta amyloid in your brain, because that was the target of the drug, right?
Right.
So Biogen what they showed was that their vaccine worked. It was amazing. After 18 months, 80% of the people, 90% of the people, all the plaques were gone.
What?
Yeah.
And this was 2010?
This is like 2000, let's say 2000, what is this, 2021? Let's say 2017.
No, we're in 2020.
2000, so I'm disoriented.
Yeah,
It's
no
just
worries.
not right.
I was like, wait, did I miss a year? What's happening?
I'm talking too
Life
much.
is flying by, I know
I
that,
know.
but not that fast.
Okay, I got the year wrong. This is bad. This is bad. Okay. So, so it was about 4 or 5 years ago. They showed that was the initial study.
Okay.
That showed in a small, what we call a phase 1 study, that the vaccine worked and it removed the plaques.
Well, that's excellent, right?
It was excellent. But the question is now, if you remove the plaques, do people get better? Because we didn't know that.
Okay.
So I'm telling you stories about how we develop drugs. So the first thing is, does the drug work to hit its target on a biological chemistry basis to remove the plaques? And it turned out the drug did that.
Wow.
It was amazing.
Yeah.
Right? That was amazing. And then it was a small study, what we call phase 1, only 160 people.
Okay.
And there was a small signal at the end of the study that people had a slower rate of decline. So what they did was they went into a big study, like 2 studies, 3,000 people, and they showed in that study, which reported out last summer, that the same thing happened. They were able to remove the plaques, and controversially, there was a signal that the people had a slower rate of decline. So right now, that drug is probably going to go to the FDA to see if it can be the first disease-modifying drug for Alzheimer's.
Would that be amazing?
It would be amazing. It'll be a first step. I mean, we've had, it's harder to develop a drug for Alzheimer's disease. Imagine that we could have a little white pill that would prevent and treat Alzheimer's disease. That would be
life-changing,
incredible, right? It would change the world.
Absolutely.
I mean, and that's it. 90% of the people who work in the pharmaceutical industry, this was said by somebody who was this CFO for Merck many years ago, 90% of the people who work in the pharmaceutical industry spend their entire careers never working on a drug that comes to market. Failure is the norm. That's how hard it is. We take these pills for granted. It's so hard to
You're
develop.
right, we do. Just think about that.
We've had, since 2004, we've had 100% failure rate in developing drugs. But you know what? We learned from every study, and we're on the cusp now of having positive studies. And, we're like 70 or 100 years behind cancer because of that delay. You asked me before, like, why between 1906 and 1970. But cancer research started in the 1910s, 1920s. And now, finally, almost 100 years later, we have effective therapies for cancer. We're like 50, 60 years behind cancer, but we're going to get there. And that's what's really exciting.
So this is like soon this could happen and be on the market.
I think we could have one of our first disease-modifying drugs in the next couple of years, maybe.
So these PET scans, is that what they're called? Are they covered by most insurance providers?
So that's a great question, right? So this is something crazy about our system. So they're not covered because Medicare decided not to cover it.
Go figure.
Because they said, basically the message we got was, why bother making the diagnosis? There's nothing that you can do about it anyway, and there's no drugs. But they were also, I think, concerned because these PET scans are expensive. They're like at the time they were $3,000 a PET scan, and I think there was a certain fear on the payment committee at Medicare that this would be very expensive. Okay. But the bias against old people, and the bias against that, if you're senile, what's the why bother making a diagnosis really got me very angry. And I actually testified before the committee, and I've been taking care of people with Alzheimer's disease for 40 years. And I said to them, how can you say there's nothing that can be done? Of course we need to take care of these people. People need care. They need education. They need counseling. They need, we need to learn about prevention and all these other things. So Medicare decided, they gave the scan what's called a coverage with evidence development, a CED. A CED means that Medicare would pay for a study to see what the value of the scan could be.
Okay.
So they agreed to pay for almost 19,000 scans around the country where people that were diagnosed by dementia experts as having dementia, right, as having Alzheimer's disease, I should say.
Right.
And then Medicare would pay for a free scan to figure out how often they were right in making the diagnosis.
Gotcha. Okay.
And it turned out that doctors who made the dementia experts who made the diagnosis of Alzheimer's disease were wrong half the time, 50% of the time.
Wow.
And, that's not to say they were wrong in saying that people were demented, but as far as the cause and what that means for the progression and the prognosis of people, and also getting people diagnosed so they can go into clinical trials.
Well, right, and there is, specific, like, what if somebody who, is an older person, let's say they go in for, like, a knee replacement surgery because they're having trouble walking.
Right.
And maybe something happens in that surgery where they're suffering mini strokes.
Right.
And it's affecting that part of the brain. And all of a sudden they're losing, like, memory, or they don't remember where they are, they can't necessarily function. That might not be Alzheimer's. That might be caused by something totally different, which is a stroke.
Right.
But it would be very similar, so those drugs wouldn't work?
Well, what you're saying is really interesting, because the foundation is actually funding studies in what's called postoperative cognitive decline.
Okay.
And we see that a lot. But you're absolutely right. Older people go into surgery. They, the family will say, they'll come to see me, and the family will say, Mom was fine before she went in for that hip replacement, and she came out and she was demented. But the fact is probably that she probably did have symptoms before she went in that were unrecognized and undiagnosed, and then had the surgery. And somehow we don't know exactly why major surgery causes postoperative decline, cognitive decline, but we know for sure that it happens, and we're funding studies at Yale and other places to try to figure it out. And one way we tried to figure it out is to do those brain scans on people going into surgery to see if they actually had
prior
Alzheimer's.
To the surgery.
Yeah, because one of the things that the scans showed once we had them for research is Alzheimer's disease. While the symptoms usually start when you're 75, the disease starts in your 40s and 50s, because we started scanning people.
Oh my gosh.
It's amazing, right?
Right.
It's like...
Well, it's scary, too.
It's scary. But the thing is, think about heart disease. You don't start getting plaques in your heart arteries when you're 75. You start getting them even when you're a teenager, right? It accumulates over the course of a lifetime.
Right.
The same thing with Alzheimer's. You start getting the plaques. We start seeing them in the 40s and in the 50s, in the early 60s. And it takes a while for enough damage to occur before somebody becomes clinically symptomatic. And
so
that's what this...
Another thing I want to talk about too in the surgery on that subject, like this pertains to my grandmother. So she had two stages of kind of dementia. She had a knee replacement surgery, and at that point they're like, no, she can't live on her own. She's losing her mind. Moved her out to Denver, and then she just snapped out of it.
Right.
And they thought, because when you're older, the anesthesia sometimes can take 6 months to wear off, is what they were saying.
Right.
So she could have still had the symptoms of the anesthesia. So she called up my father one day and she said, get me out of this loony bin. I'm going home.
Right.
Luckily, they hadn't sold her house, so he said, fine. So packed up all her stuff and back to North Carolina she went. And she was there for probably another year and a half, and then it got bad. And now she's like in memory care now.
Right. So dementia is a chronic form of cognitive decline.
Okay.
It has to be more than 6 weeks. Usually it's years, months to years, where people give a history of having cognitive decline. But there's an acute form of cognitive impairment called delirium. And delirium affects people who go to surgery. So what might have happened to your grandmother was that during the operation and immediately post-operatively, she had a delirium, which is usually reversible. And it might have been through the anesthesia. We don't really know what causes it completely. But she might have had a post-operative delirium that recovered, and then she was back to baseline. And the people that have Alzheimer's disease are more at risk of getting delirium. But it's reversible, but usually there's like a stepwise decline. So, Mom, your grandmother might have been up here, and then she had the surgery. She got a post-operative delirium. She took a step down in her cognitive function. She recovered from the delirium, but she didn't come all the way back. And then the disease was underlying all that time because she probably was cooking it for 20, 30 years before that anyway. Right. And it finally came out. So
let's talk about some steps that people can take as far as like prevention goes. Like, how do you start preventing this from happening?
So what's been learned, and we actually have data on this, is that, the soundbite I would give people is what's good for your heart is good for your brain. Because people are used to living a healthy lifestyle with the idea that, if I exercise 150 minutes or more a week, if I eat a Mediterranean diet with a lot of fruits and vegetables, if I don't smoke, if I don't drink alcohol, if I manage my diabetes and my hypertension, if I get sleep, if I avoid stress, these are the main tenets of how to do prevention for heart disease. They also apply to your brain.
Okay, well, that's good.
And there's evidence for this, that it really, these kinds of interventions actually can decrease the risk of becoming demented and getting Alzheimer's disease. The only one other thing that's a little different from the heart disease prevention is staying socially and occupationally engaged, because your brain is what we call plastic. In other words, it is really true with your brain that just like your muscles, that either you use it or lose it, right? And so older people who become socially isolated, or even younger people who become socially isolated, the brain can literally atrophy. We can see it on MRI brain scans now.
That's why I've always told my dad, I said, you can't retire. You can slow down, but you can't retire, because I am convinced retirement kills people.
It does. I mean, it certainly can affect the brain. If people don't find other ways to stay socially or volunteering or occupationally engaged. I had a patient the other day who sits home alone all day. And it's a very sad thing, but it's also, bad for your brain. So that's another.
Did you tell them to get out and join a club and do something?
Well, he came in with his family. The wife was still working, so she, would leave him home at 8, 9 o'clock in the morning and come home at 5. And he, because he had Alzheimer's, he couldn't make plans for himself, and they weren't planning for him, so he had no life. And, it was really sad. So I wanted to try to get the family to find this man who had been a very successful technology entrepreneur, a companion, basically, and, have him figure out a life and do activities that are appropriate for his level of functioning. So even though he had some cognitive impairment with memory problems and so on, he could still go out for walks, enjoy a beautiful day, listen to music, maybe write his, dictate his memoirs. I mean, whatever it is, it's, there are ways to find quality of life, even when you have cognitive impairment.
Right. So people that are going into retirement, it's very important, you would say, to like map out a plan of activities, because that's where your brain. Because I remember, like, my grandma, she would do crossword puzzles all the time. That was like her thing.
Right. So
she doesn't do them anymore, but she did.
Well, the thing about crossword puzzles and computer games, people ask me about that stuff. Computer training, is like, particularly for crossword puzzles, for example, you get good at crossword puzzles, right? Okay. But it's like if you were exercising and you were doing weight training on your biceps, right? Well, it doesn't do anything for your legs. There's no cross training. If you're doing weight training, it doesn't cross over to your aerobics, right? Right. So your brain is the same way. You have all these cognitive tasks that, cognitive functions. You have language, you have speech, you have, voice, you have arithmetic, you have judgment. There's certain parameters of cognitive function that are normal that compose it. And so if you do crossword puzzles, you get good at crossword puzzles, but it doesn't necessarily improve your processing speed, your ability to multitask, to make judgments, your language, and all those other things that you want to do. And that's why socialization is the best thing, because it uses all of your brain functions that are out there.
Okay, so being social is the most important.
Yeah, I think, rather than having my patients sit in front of a computer and try to do computer training, which trains them on a particular task, and it might work.
Right.
The better thing, for quality of life, but also for training your brain and keeping it, in a robust state of health, is to interact with people. Because that requires all your senses, your visuals, your smell, your social senses, your intellect. That's the best way to do it.
Right. And it seems that, when you go into these older, like assisted living homes or independent living homes, that they seem to be very activity focused.
Right.
Which is good, because it's like we're all together on this planet.
Yeah.
And we're meant to interact with each other and things of that sort. But I want to talk about early onset Alzheimer's a little bit more.
Okay.
Is that happen because it's hereditary, or was it something possibly in their diet that might have led to that?
Well, again, the word early onset is confusing, I think, for people. So early onset can mean they're in the early stages of senile dementia, let's say. And I find the word early onset a little confusing. I like to use familial Alzheimer's, because most of these people have families where they have it, or if we're going to use early onset, let's make sure we define it. These are people that are getting demented in their 30s and 40s and 50s, so it's very rare.
Right, because I think this guy I'm thinking of, I won't obviously say his name, but very successful, and all of a sudden one summer we were talking to him, and my dad's like, something's not right. Like, he just seems, and then sure enough that year, and this guy was like early 60s.
Yeah. Well, early 60s
was working. He wasn't retired.
Yeah. So there's another gene, which is a risk factor. It's not a mutation that causes Alzheimer's, right? If you have these mutations that cause Alzheimer's, you're going to get it. But there's another gene that's called a genetic risk factor.
So real quick, if you have that gene, is there a way to test if you have that gene?
Yes.
And that's through
Just come to the doctor's office and we draw your blood.
Oh, so it can be done right through a blood test?
Right through a blood test.
Wow, that's scary, but also very good to know.
Yeah.
And if you find out you have that gene, what do you do?
So, again, talking about the genetic risk factor, there's a protein called apolipoprotein E. And this is a protein in the blood and in your brain that carries cholesterol. We think it has many different functions in the brain. And there's 3 types of ApoE. ApoE2, ApoE3, and ApoE4.
Okay.
So 70% of people have ApoE3. And everybody's got 2 genes for everything, one from mom, one from dad.
Right.
So people could be 2-3, 3-3, 3-4, 4-4, like that.
Okay.
So 70% of people will have a 3 in some combination, right? About 5% of people will have a 2, and about 25% of people will have a 4, something like that.
Okay.
And I know that doesn't add up to 100, but I'm pretty close.
Right.
So 3, let's say, is the usual risk of getting Alzheimer's disease.
And 70% of the people have this?
Have the 3. So that's the most common thing. 70% of people in the community that are normal have a 3. 70% of people have a 3.
Okay.
People that have a 2 are protected against Alzheimer's disease. And people who have a 4, if you have a 1-4, like let's say you're a 3-4, then your risk of getting Alzheimer's is 5 times the general population. And if you're a double 4, then your risk of getting Alzheimer's is 15 times the general population. And if you're a double 4, you're going to get it 10 years earlier than the average person. So if the average person's going to get Alzheimer's at 75, you're going to get it at 65 or 62 like your friend did. So if your friend came into my office at 62, 65 with the disease, I would do the ApoE testing on them to find out if he's got the ApoE4 gene. And usually those people have a familial history, a family history of having Alzheimer's, like mom or dad or something like that. Now, we've known about this ApoE4 for 25 years.
Okay.
Okay? And we know that about 60%, well, it's only 20% of the population, about 60% of people with Alzheimer's have ApoE4. So there's a real low-hanging fruit there, like something we got to fix, right?
Well, absolutely.
So we've been trying as a field, going back to how hard it is to develop a drug. Here's something we know about that's a major risk factor. Now, not everybody that's got a 4 is going to get Alzheimer's, but if you have it, your risk is much greater. So
why would anyone want to get this test? Like, I don't think I'd want to know.
Right. So the thing is, that's another story, but the thing is, I'm a practicing physician, right? So when I'm dealing with patients, I'm dealing with individuals, okay? So I have people like you, who may be young, their father had Alzheimer's. They don't want to know. They don't want to be scared. They think it'll make them too anxious, and they don't want to know.
Okay.
But there's other people like you, or maybe your friend who has symptoms. They want to know, and a lot of people just want to. They want to know what's going on. They want to know what's causing it, for a couple of reasons. One is,
so if they're having symptoms, they want to know.
Or even if let's say you're 55 years old, and your mother, who's now 80, has Alzheimer's, but you have 2 or 3 people in the family. There's clearly a genetic risk. It's late onset. Maybe somebody in the family got it at 65. So there's a familial risk there, and you're 50, and you want to know because you want to know what your risk is, because maybe it'll change your lifestyle. Maybe it'll help you do advanced care planning. Maybe you'll do your wills. Maybe you'll apply appoint a healthcare proxy. Maybe you'll get involved in research to fix the ApoE4.
That's true.
And some people just want to know. So we've been trying to fix the ApoE4 for 25 years, and I think we have a strategy now over at Cornell, and it's gene therapy.
Okay.
And what we're doing is we're funding studies there where we're taking what's called a non-infectious virus. Okay? So it's a virus, it's an adenovirus, very common, causes colds and stuff like this, but this is a non-infectious form of the virus. Okay. And we put the DNA for ApoE2 into the virus. Okay. So the virus starts making ApoE2.
Wow.
And then we take that virus and inject it into the brain.
Like through a needle?
Through a needle.
Wow.
And then you get ApoE2 in the brain. And we know that people that are ApoE2/4, right, they have a normal risk of getting Alzheimer's disease. So the presence of the ApoE2 offsets the risk of ApoE4. And so we're in phase 1 clinical trials right now with this vaccine, which is a virus gene therapy to fix ApoE4.
And how does somebody get involved to participate in the trials?
Well, if you either know if you're ApoE4, and right now we're going to do it in people that are double 4 because they're the most at risk, then you can contact the foundation and we can refer you to the investigator. It's it's over at Weill Cornell over on the east side, and basically that's the only place I know of in the world that's actually doing this work right now.
And they're having success with it?
Well, we're in phase 1 right now.
Okay.
And we'll be going into phase 2, which will be where we'll test it for efficacy for the first time. Right now we're in the safety phase, but it's amazing because we've been funding this thing for 7 or 8 years.
Wow.
Started out in, the chemistry and the virology, and then went into mice and showed that it worked in mice, and then we went into non-human primates and showed that it worked in non-human primates, and then we did all the regulatory science around getting it ready for the FDA, and then the FDA gave us approval to go into human beings, and now we're in human beings.
So when do you think if you had to protect, when do you think we would have a cure for this disease?
I don't think we're going to have a cure. I don't like to use the word cure because it really creates unrealistic expectations, and part of the reason is if you think of all the diseases of aging, like heart disease. I mean, we have these amazing drugs called statins, right?
Yeah.
And they're amazing drugs, and they've really helped to reduce the risk of death from heart disease, right? And they prevent second heart attacks in a lot of people. But heart disease remains the leading killer in the United States.
Yes.
And so I don't like to think about cure. I like to think about having effective treatments. And I think within 5 years we'll have effective treatments that'll start to incrementally reduce the risk and treat people. Because we're going to have to first show that drugs work in treatment to slow down the disease once people have it.
Right.
And then we'll go into prevention trials. And we're already starting to see prevention clinical trials.
That's great.
And the way we can do prevention is because we have that brain scan. Because, right, you do the brain scan, you find people before they're symptomatic, and you can treat them to prevent them from becoming symptomatic.
So now the insurance companies or Medicare will most likely
if we have
cover
treatments,
these?
The companies will pay. But the big thing that's happening now is we're working with Bill Gates.
Oh, nice.
And with Jeff Bezos and Melinda Bezos and some other, philanthropists. We have a $50 million program called the Diagnostics Accelerator.
Wow.
And one of the main goals of the Diagnostics Accelerator is to develop a blood test for Alzheimer's disease.
Interesting.
And I predict we're going to have a blood test for Alzheimer's disease in about 3 years.
That's exciting.
And that's not going to be expensive.
Okay.
And it correlates with what the brain scan tells us or what spinal taps tell us.
So when you say the blood test for Alzheimer's, though, you already have the blood test to find the APO.
That's for genetic risk.
Okay, for genetics. But now you can do a blood test simply to say, do you have Alzheimer's? Do you not?
Right, because I told you about the beta amyloid, right?
Right.
And that's it may not be the cause of Alzheimer's, but it's a characteristic feature of the disease, right? It's a diagnostic hallmark on the pathology, on the PET scan, which finds the pathology. And what we find is that there's beta amyloid in the blood. And when people have levels in the blood, then we can say diagnostically that they have Alzheimer's. It correlates, what's in the blood correlates with what's in the brain. And that's how we validate the blood test and develop it and bring it to market. And when we have a blood test, then all these things become even better, because now when we're running clinical trials, it'll reduce the cost of clinical trials. We'll be able to find people more easily for the clinical trials, because less than 5% of people with Alzheimer's disease go into clinical trials. And one phase 3 clinical trial costs $400 million.
Wow.
And you have to run 2, 3, 4 trials to get a drug approved. So this is enormously expensive. And 50% of the cost of running a trial is finding the patients.
Right.
So if we had a blood test, it would reduce the cost of the trials immensely, and would also improve early diagnosis and prevention.
Wow. And so are you saying that Alzheimer's is purely a genetic disease?
No, not at all. It's
okay.
Not,
So do you think our products that we're using every day might be?
What kind of products?
Just they're saying there's so many toxins in all the everyday products that we're using that they're saying could cause cancer. And do you think that contributes to?
Back about 30 years ago, there was a concern that aluminum and these aluminum products for, sweating under your arms.
Yeah.
But there's really no evidence. And,
okay.
It's possible that toxins contribute, but we don't have any evidence. I mean, I would say, the main toxin that predisposes people to dementia in general is things like smoking and alcohol, too much alcohol. And that kind of thing. But there's really like perfumes and antiperspirants and these kinds of things. There's really no evidence. Lead can affect your brain, but when lead affects the brain, it's usually developmental. It's in young children, and it's a different disease than Alzheimer's, as far as we know.
Interesting. So what else? Before we kind of wrap up, can you share with people that might be listening that have somebody that they is suffering from Alzheimer's to kind of help give them a little bit of peace of mind?
I've been taking care of people with Alzheimer's disease for 40 years, and I'm still shocked at the kind of care that people get.
Yeah.
It's just so sad. I mean, people with Alzheimer's disease and their families, they need a really good, experienced doctor who can be partners with them throughout the course of the disease, from early diagnosis that people say, like, what's going on? There's a change in personality. He's aggressive now. I don't understand it. We need, he doesn't remember everything. What's going on? Well, I'm sorry, your husband has Alzheimer's disease. Oh, I understand. What can I do?
Yeah.
And then we'd have to teach spouses, for example, how to care for someone with Alzheimer's. And then the average course is somewhere between 6 and 9 years. It's a horrible way to spend end of life. But, we can provide quality of care for these people. You need a good provider, maybe not even necessarily a doctor, but someone who's really an expert in the care of people with Alzheimer's to help. Hippocrates said, whenever 2,500 years ago, that the role of the physician is sometimes to treat, often to relieve pain, and always to comfort.
Yeah.
And I think today we've forgotten that most chronic diseases of old age cannot be cured, but we need to help people manage through it. And I'm a firm believer that that's something we can do today to help people get through this horrible nightmare.
Oh, absolutely. And the people that have Alzheimer's, like, because they don't really remember things, do they know?
So a very early symptom of Alzheimer's is something, the technical term is anosognosia, which is a big word, but it means loss of insight. So you might be sitting across the consultation table with me, and your husband might be next to you, and I'd say, I'm sorry, if you want to know, I would say you have Alzheimer's, and you'd look at me and say, oh, okay, I have Alzheimer's, but you don't understand the meaning. You lose insight into what it is. And so, the loss of insight often inhibits people from really understanding their diagnosis or even the problems. And a lot of times, people have obvious memory problems, and it's not that they're denying it. People think, oh, my husband's denying it. I keep telling him, you don't remember anything, and and it results in a big fight. And I say to the wife, the guy's got a disease. He can't remember. His memory banks are shot.
So do you think it affects the loved ones more than the actual patient?
Caregiver stress in this disease is a major factor, and that's why we need a caring provider, doctor, nurse practitioner, whatever it is, that can work with the spouse or the caregiver. Most often, it's 70% of the time it's women, usually daughters or wives, who are going to care for the patient. Who can, are under stress, and maybe when do we bring in home care? When do we refer people to home care so that the caregiver can get respite? Because caregivers are at increased risk for depression and hospitalization and all these other bad things.
So how do people ensure that they have enough money to pay for this stuff?
People don't have enough money to pay for this stuff.
And that's the thing, because you talk about in-home care. I mean, that's very expensive. I mean, my grandmother's memory care, I think, is $10,000 a month.
Exactly, about $120,000 a year. And it's often not paid for by insurance.
Exactly. So what are some steps that people can take that you would suggest, maybe some funds or that you kind of mentioned before, to make sure that they do have those funds should that happen?
What happens more often than not is that people spend down whatever savings they have. I mean, if you're talking about the average American that has, $50,000 in retirement savings, they spend it down with care, and they go into poverty. Very often, it's a woman's problem, because the women are often caring for men, and then the husband dies, and the woman is left in poverty and goes on Medicaid and ends up in a Medicaid nursing home. But even the men, I mean, it puts people into poverty, and we don't have good home care benefits in this country. We don't have good long-term care benefits in this country.
Are there things being done to help that?
Well, there's long-term care insurance,
right?
Which provides some benefit. People have to start purchasing it, years before they become impaired. So people can purchase if they have enough money.
So it's almost like life insurance for yourself.
It's life insurance for if you need care in your old age, or if you become disabled. But it's not cheap. And again, if you're talking about the average person may not really have money for long-term care insurance when you're trying to pay for your kid's school and all that. So it's a real economically, Alzheimer's disease is the most expensive disease in every developed country in the world, more than diabetes and hypertension and cancer, because you have all the hospital costs and all the medical costs and all the lost caregiver productivity and the long-term care costs. So it's upwards this year of almost $300 billion cost to the United States just to care for the current group of people with Alzheimer's disease.
And so when you guys come out and finally get approved with this drug, this treatment, that obviously will significantly reduce that cost.
That's the hope.
Is the hope, yeah.
Yes, exactly.
So where can our listeners go to find you and find more information on the research that you guys are doing and things of that sort?
Well,
and thank you for all the research you're doing.
Well, thank you for asking.
It's really amazing.
Thank you, Madison. Yeah, so our website is, we're the Alzheimer's Drug Discovery Foundation.
Alzheimer's, Drug Discovery Foundation.
Correct, and the website is ALZ.
ALZ,
Discovery.
Okay.
All one word, alzdiscovery.org.
Okay.
And it's all there.
Perfect. And is there a place they can go and donate if they want to donate?
There's a little button on the front page, and we'd love to have them push that button and give us some help to find a cure for Alzheimer's. Well, I don't want to use the word cure, but to find effective treatments for Alzheimer's in the next few years. Yes, we have over 25 clinical trials going on. We've funded in over 20 countries. We fund biotech companies that have programs in drug development for Alzheimer's disease, and we've deployed over $140 million over the last 20 years. So we've funded over 600 programs in 20 countries for Alzheimer's drug development. So it's an exciting time to be in this.
Yeah, and you must be so proud of yourself you're really making a difference.
Yeah, thank you. I appreciate that.
And it's really amazing that you're on the, boots on the ground, right into this thing that is affected so many people.
Yeah, and we have a really unique philanthropic model. It's called venture philanthropy.
Okay.
And by the way, since we were founded through a private foundation that was started by the Lauder family, the Estee Lauder family.
Okay.
They pay all of the overhead for the foundation. So
nice.
When people donate to us, 100% of every dollar that's donated to us goes to the development of new drugs for Alzheimer's disease.
And I think that's I'm going to have you repeat that because I think that's very important because some people, when they are donating to charities, they're thinking, how much of this is actually going to benefit and help the cause, because we do have to pay these people to do a job, to keep the overhead. So they pay for all the overhead, so 100% goes to direct research.
Which
is unbelievable.
Yeah, we have
fantastic.
We have 8 full-time neuroscientists on staff, and I've been doing this over 40 years now.
Wow.
And it's all paid for by the Estee Lauder family.
Oh, isn't that great? And where are you guys based out of? New York?
We're in Midtown on 57th and 6th.
So this is where all the research is happening, right here?
Well, we don't do research in our labs.
Okay.
I mean, we don't have labs. We're searching the world every day for new programs and talking with investigators and helping them to develop drug programs and clinical trials. And then we provide the funding for those trials.
That's fantastic. Well, exciting stuff ahead.
Thank you.
And is there anything else you want to leave us with before we depart?
Well, I want to say it's been wonderful talking to you, and I really appreciate the opportunity to tell our story.
Absolutely, and I appreciate you coming on and being my guest on Next to Madison.
Thank you.
So this was fun and such a great topic that isn't talked about enough. And kind of diving into it. So thank you for educating myself and the listeners as well.
Thanks, Madison.
All right, you guys. And thank you for listening to another episode of Next to Madison. We'll see you guys next time to find out who's next. Hi, your host, Madison Malloy here. I just wanted to remind you guys to please follow the show on social media at Next to Madison. And if you have any questions or suggestions for the show, or you feel that you would be a great guest on the show and would love to be considered, please feel free to email me at nexttomadison@gmail.com. Don't forget to subscribe to the show on all podcast platforms. And I thank you again for listening.